All right, good morning, everyone, and welcome to Head Talks. This is the last grand rounds that we have for 2022. We'll be taking a winter break after this and then coming back in early January. So Head Talks, for those of you who have come to grand rounds before, this is an annual tradition that began actually 9 years ago under Dr. DeBonis. Today we have three talks that will be given by residents who are going to be speaking about ideas in the field of psychiatry, psychology, and mental health that they're most passionate about. The talks are limited to about 10 minutes each, which is a hard time limit to stick with, but each of the residents has put a lot of time, practice, and effort into really polishing their talks to deliver some interesting and thought-provoking content in a short period of time. These topics tend to generate a lot of questions and discussions, but just in the interest of giving people enough time to present, please hold your questions until the very end. You can put them in the Q&A function, even during the talk, but we'll wait until the end to address them. And make sure that when you're submitting a question, make it clear which speaker you're addressing. And with that introduction, I wanted to bring on Dr. Mary Youssef, who I'm pleased to introduce as our first speaker today. Dr. Youssef is one of our chief residents this year. She graduated with a combined MD PhD from Columbia, where she was recognized as being one of their star medical students via induction into both AOA and the Gold Humanism Society. Since coming to UCLA, Dr. Youssef has shown herself to be a quiet but effective leader, making structural changes to better the lives of her co-residents and demonstrating a level of organization and passion that consistently leaves me in awe. Today, Dr. Youssef is going to be talking about anxiety and doctors. So without further delay, I hand it over to Dr. Youssef.
Thank you, Dr. Hout, for that very nice introduction, and thank you everyone for being here today. I'm going to take a second to share my screen with you. So today I'm going to be talking about anxiety in doctors, examining if there are unique characteristics of doctors that contribute to our anxiety. And this topic is of interest to me because it feels like so many of my peers and myself so often have to deal with anxiety and talk to each other about our anxiety. I'm going to start with these surgeons' words reflecting on their anxiety. They write, "What helped me become successful, being self-critical and a perfectionist with high expectations, later became the source of my problems." This quote encapsulates exactly how I approach this topic, thinking about if the personality and behavioral characteristics that help us become doctors are the same that contribute to our anxiety once we are doctors. In this presentation, I'm going to talk about the rates of anxiety and depression in doctors, the personality characteristics of doctors, how these traits can contribute to anxiety, and what can we do about all of this. Since anxiety and depression are so often comorbid, I find that I can't talk about one without including the other. And for both depression and anxiety, the rates in physicians and medical trainees are higher than in the general population, suggesting that there may be experiences or characteristics unique to doctors that contribute to these symptoms. Also, female doctors tend to have higher rates of depression and anxiety compared to male doctors. In the research literature, the increased rate of depression and anxiety in doctors is often attributed to the high stress culture of medicine, the long work hours, the financial burden of educational debt, and the perceptions of inadequacy. Perceptions of inadequacy certainly rings true to me based on my own experiences and those shared by my peers. And that thinking about this is what led me to focus on how personality traits may contribute to physician anxiety. When looking at the research literature, most studies of personality and anxiety in physicians focus on the big 5 personality traits shown here. And the most consistent finding in these studies is that higher levels of neuroticism correlates with increased anxiety and psychological distress. However, since neuroticism is defined as being prone to anxiety, unhappiness, and negative emotions, I didn't find these studies as particularly useful in understanding how physician personality traits may contribute to their anxiety. So then I turned again to physician writings to think about what personality characteristics may contribute to our anxiety. And here, Dr. Jane Barker, a psychiatrist who's written extensively about physician anxiety, writes, as a profession, we are tough on ourselves, often having completely unrealistic expectations of ourselves. We expect ourselves to be superhuman, perfectionists, and on top of that, to be altruistic and compassionate towards our patients. She quotes a surgical trainee who writes, my biggest problem seems to be performance, having to get up in front of crowds for presentations, and even sometimes during surgery, I find myself dizzy, nauseated, and on the verge of vomiting. Thinking about these quotes and back to my opening quote about how the characteristics that allow us to become successful enough in our educational careers to actually become doctors may be the same traits that contribute to our anxiety once we are doctors. I reflected on my own and my peers' experiences to identify traits that fit this schema. The most prominent to me is perfectionism. Perfectionism in grade school and medical school is often adaptive as it motivates us to study to achieve the high scores necessary to gain admission to the next step in our education. However, perfectionism can lead to distress as a doctor, as I've seen in my internal medicine colleagues who reprimand themselves for making a different choice than the attending would have made when the resident was alone on an overnight shift, even though there were no bad patient outcomes. Or when I chastised myself just last week for not asking a patient's permission before exploring treatment options for sexual side effects of medications, once it became clear to me that she was uncomfortable with this discussion. Another trait that can contribute to both success and anxiety in doctors is people pleasing. People pleasing as a college and medical student can lead your advisors to think very positively of us, leading to high praise in letters of recommendation, and these letters of recommendation are essential in any admissions process. But then my desire to people please prevents me from ending most of my appointments on time because I assume my patients want more time with me and I don't want to make them upset with me by ending the appointment. Also, women are more likely to be people pleasers than men, which is thought to be due to social conditioning. And I wonder if this may contribute to the higher rates of anxiety and depression in female compared to male doctors. Thirdly, a fear of criticism can compel medical students to prepare well for daily rounds and get outstanding evaluations. But then it can become impairing like it did for me for this presentation, where I spent weeks avoiding working on it out of fear that I'd be judged poorly. My assumption that the audience would think that I did a bad job made it too anxiety provoking to even start working on it, causing me to have weeks of unnecessary anxiety and to have to stay up late multiple nights this week to finish working on it. These are examples of many personality traits that can contribute to physician anxiety, and it would be incorrect to assume that these only become anxiety-provoking once students become doctors. When looking at the educational path to become a doctor, it can be easy to see how doctors end up with the traits just described. The need to have high grades and many extracurricular activities, leadership, volunteering, etc., to build an excellent resume, likely both trains students to focus on performance and selects for those with this predisposition. As a young student, I liked getting good grades, likely reinforced by my parents' praise when I did so. But by the time I got to medical school, the necessity of getting perfect grades was driven by my terror of not getting into my first choice residency. Additionally, with the constant evaluation in the form of tests and papers, then daily evaluation of what seems to be our whole being when on clinical rotations, it's no wonder that we view everything we do as being evaluated. Additionally, decades spent as students and trainees contributes to an infantile state of mind. In medical school, in school, the teacher knows all and imparts knowledge onto the student. In medical school and residency, we have to run every decision we make by someone else well into our 20s and 30s, and even have to ask permission to go to the bathroom at times when on clinical rotations in medical school. This prolonged period of having to look to external sources for permission and guidance delays the opportunity for self-determination and autonomy and the building of self-esteem that is necessary for coping with anxiety. Also, the time spent in education causes many to delay real life experiences like getting a job, finding a partner, having children, buying a home, and all the other real world experiences that our similar age counterparts have that, if we had, could help put our clinical work experiences into a real life context. So, what can we do about all of this? In psychodynamic psychotherapy, we see the bringing of the unconscious to conscious awareness as a way to cope with and heal anxiety. Increasing doctors' self-awareness about how their personality traits can contribute to their anxiety can help bring clarity to our psychological distress and help us see our feelings as products of our temperament and experiences rather than as personal failings. I found my own personal therapy incredibly useful for helping me recognize the traits in myself that drive my anxiety. Additionally, the acknowledgement that we will make mistakes and as humans we cannot be perfect is not one that we're often allowed to make, but one that can help relieve the burden of perfection that we feel. I feel lucky to be in psychiatry where my mentors have taught me that it can be helpful to recognize all the ways that we aren't perfect and to be curious about my mistakes. We can also reconsider our review processes and what we want to value and select for. Even in our psychiatry residency holistic review process, we evaluate applicants' clinical performance, extracurricular activities, and contributions to the community, which are all measures of how hard they worked and how well they did. It seems impossible to conceive of this, but what if we selected based on how much time applicants spent with friends and family and how invested they are in their hobbies? How would that affect their anxiety when they become doctors? And of course, since anxiety and depression impair our ability to care for patients and contribute to physician suicide, which occurs at higher rates than in the general population, improving access to psychiatric care, including time to access these services and acceptance of doctors accessing mental health care, is essential in helping doctors manage their distress in these areas. For this talk, I want to thank my co-residents in this program who are shown in this picture at our yearly retreat, whose stories helped to shape my ideas for this presentation. And not pictured here are the many friends and classmates whose experiences also helped to shape my thoughts here. And all of their support and encouragement has been vital in helping me get through all of school and residency. I also want to thank my program directors and my attendings for their openness in the way that they talked about experiences that they have found difficult, and particularly Dr. Helt for his feedback on this presentation and helping to calm my anxiety about it. I also want to thank my therapy supervisors, Dr. Shira Volmer and Dr. Zeb Little, whose perspectives on anxiety and vulnerability helped shape the thoughts I've shared with you here today. And finally, I want to thank my parents who are both here listening today and who are proud to have helped shape the perfectionism that both contributed to my success and my anxiety. And I want to thank you all for listening today.
Thank you so much, Dr. Youssef. Really appreciate the time you put into that and for sharing that with us. All right, next up, I'm excited to introduce Dr. Karen Mendez. Dr. Mendez is a true UCLA success story. She did her bachelor's degree, MD, and is now doing her residency all here at our campus. I had the privilege of working with Dr. Mendez on her first day of second year working in this hospital as a resident. And even on that first day, she deeply impressed me with her commitment to her patients and her very compassionate and thoughtful approach to even some incredibly challenging situations that we encountered. This year, I've gotten to know Dr. Mendez better through her work in the clinician educator concentration, and I've really loved seeing her apply that same considerate approach to teaching as she does to patient care. Today, Dr. Mendez will be showing us how emotional focused therapy can help us to better understand our patients and better treat their situations that they find themselves in. So please give your full attention to Dr. Mendez.
Thank you so much for your kind words, Dr. Held. So I'm Karen, I'm one of the PGY4s, and today I want to talk to you about the fact that adults can have meltdowns too, and give you a very brief introduction to emotionally focused therapy. And I have no disclosures. So to do this, I would like to start with a case. This is Mark. This is a 30-year-old man who reports feeling dissatisfied with his life. He's a lawyer and he's been married for 5 years. He comes into your office and he shares that he's particularly struggling to enjoy his weekends. He shares that he experiences irritability, which is mainly displayed in multiple fights with his husband. And he shares with you that this leaves him feeling sad with low energy and low motivation. So as a psychiatrist, I want you to go ahead and pick one choice of how you may start treating Mark. So A, start an antidepressant, B, a Lamictal titration, maybe refer him to individuals therapy, couples therapy, or do all of the above. So just take a moment for yourself, pick one. My hope is that by the end of this presentation, choice C, a referral to couples therapy, will be among the top choices in your treatment plan. To talk about emotionally focused therapy, or EFT, we first need to talk about what is at its core, and that is attachment. Staying close to a protective loved one is a survival mechanism. So early in life, an infant seeks attachment with his or her caregiver. And if that emotional bond is threatened, the fight, flight, freeze sympathetic response is activated. And this is very primal. We can see this through the steel face test designed by Dr. Edward Tronick at Harvard. So here we see an infant and her caregiver, and they're looking at each other, they're joining in the experience, the infant's pointing, the caregiver looks where the infant's pointing, they're smiling, and this very positive connection in a secure attachment. As part of the still face test, the caregiver is asked to keep a still face, despite what the infant may do. The infant very quickly notices this. And as suspected, the infant then engages in these positive attempts to reconnect with mom. Smiles, points, because this is what used to work. If no response, we don't hear it here, but the infant cries and screams and more forcefully reaches for mom. Still no response, the infant may actually start engaging in some negative attempts for connection, like withdrawing. And if still no response, the infant will go into a full meltdown, lose posture, and just cry unconsolably. So in this experiment, the mom then breaks a still face and the infant and mom reconnect, and the infant is just fine. The need for attachment and connection expands throughout a lifetime. And just like an infant and caregiver, we may actually see this in adults in the form of romantic relationships. When a connection in a romantic relationship is threatened, adults too will get a primal survival response activated. And very similar to the infant, in very similar way that an infant will react to a caregiver, adults too will reach, protest, push, withdraw, and if not getting that connection restored, adults too will go into a full meltdown. And as adults, if a person goes into a full meltdown, that may not necessarily mean that the adult is sick, but this is rather the expected response to a threatened connection. However, as adults, when each partner senses that disconnect between each other, adults may respond or react or reach in an attempt for connection that becomes more threatening for the other person, making a spiral go that would only leave each person feeling alone and disconnected. And then that may be Mark walking in the office. So how do we see this playing out in adults? It may start like something like this. Mark says, You left a dirty dish out, looking angry. Peter, his husband, maybe becomes a little more defensive, feeling attacked, says, I'll do it later, it's not a big deal. But this is someone dismissive to Mark that is reaching for connection. So he may just become even more angry. I had asked you to do it last night, you just never listen. Uh-oh, this is threatening for Peter, and opposite to Mark, where he's maybe becoming more activated and sort of in the fight process of that sympathetic nervous response. Maybe Peter is freezing, sensing danger, and again, putting this wall. There you go again, fighting for no reason, sort of defending himself. Uh-oh, Mark says, now what, are you just going to ignore me? And you can see how the cycle goes on and on. He's looking scarier. Peter needs to build a bigger wall. I have nothing to say. That's right, you don't care, just like you don't care about me. And at this point, each partner is on opposite sides of the wall, again, feeling disconnected. At this point, Peter doesn't even respond anymore, and Mark goes into a full meltdown. Emotionally focused therapy is experiential, and it focuses on the present. It gives space for couples to explore the response to a threatened connection. Through EFT, couples will learn about this negative cycle and spiral, and they will team up against this cycle. Couples do so by slowing down and exploring the deeper emotional experience for each other. Couples get an opportunity to reenact these interactions. What may this look like? So for Mark, when he sees that dirty dish left out, he may actually be feeling like, I feel ignored. I'm struggling and I feel alone. I feel uncared for and loved. So we are sort of digging deeper in this emotional experience. I miss you. And we can see now that Mark now is in a vulnerable place where he's not looking angry and threatening. And let's explore it now from Peter's perspective, right? So all of a sudden he's relaxing and here goes Mark screaming. And for Peter, it may look like, I am confused. I don't understand why we're fighting and I don't know how to make it right. I am scared to lose you. I am sad to disappoint you. And so now each partner has had an opportunity to explore what's underneath. More importantly, to reenact it in session, to share it with each other. And in this vulnerable place, they can find, hopefully, compassion for each other and reconnect. The goal of emotionally focused therapy is for couples to create a more secure emotional attachment with each other. So Mark and Peter were referred to emotionally focused therapy, and they did just that. They learned that when they argue or they were in the cycle, it wasn't about the superficial topic like a dirty dish out or running late. It was rather about their connection being threatened. They learned to slow down and share their emotions. And they learned that when sharing their emotions with each other, they could then connect in compassion. That's it.
All right. Thank you so much, Dr. Mendez. Really appreciate it, kind of seeing that window into the emotions behind an everyday conversation that people might have. So thank you for that. All right. And with that, I will transition over to our final talk for the day. It is my absolute privilege to introduce Dr. Jeremy Flores, who is another one of our chief residents this year. Dr. Flores is a resident who's been a really consistent force here at UCLA throughout various stages of his career. Like Dr. Mendez, he came here for undergrad, medical school, and now residency. I first got to know Jeremy as a medical student, and I remember even then being struck by his interpersonal warmth and genuine desire to improve the world around him through whatever ways possible. He's been a consistent leader here in our residency, as well as in the school more broadly, especially around LGBTQ+ issues, and has actually been interested in teaching even before medical school, where he taught math as part of Teach for America. So today for you, Dr. Flores will bring those two interests together to talk about the history of homosexuality in psychiatry. So very excited to hand it over now to Dr. Flores.
Thank you so much for that warm introduction, Dr. Halt, and good morning, everyone. Very excited to be here and give my talk. Let me just go ahead and get this shared. Okay, so let's go ahead and get started. So like Dr. Halt mentioned, my head's talk is on the history of homosexuality in psychiatry, a brief history. So I wanted to start just by talking about like, why did I pick this topic? Well, one, besides the fact that I myself am a gay man and have kind of an inherent interest in this, a natural draw to it, I would say actually mostly became interested after I listened to a podcast, This American Life. They had an episode called 81 Words, and they basically kind of talked about the removal of homosexuality from the DSM. Listening to this episode, 81 Words, was a really eye-opening experience for me, just because hearing it, I learned that there was so much history that I didn't know. I was a psychiatrist. I felt like I kind of am aware of these things, but listening to it, there's just a lot that I was surprised by and a lot that I learned from it. And it made me interested in wanting to learn a little bit more. So I went on kind of in my own journey, kind of looking into the history, and I wanted to share a little bit of that journey with you today. Few caveats with my talk. Number one, that the talk I'm going to give is a very Anglo-European centric view of history. There are many more stories, cultures, and histories that I don't cover here. This history is also a very white, gay, cis male view. And there are many other stories that aren't covered, such as transgender, bisexual, lesbian, intersex, and other LGBTQ plus histories. And then finally, I am by no means an expert on this topic. This, like I had mentioned, was just something that I became interested in and wanted to explore a little bit more. And so it is just a brief history. With that said, I think for me, it was helpful to learn about this, to contextualize kind of how we got to where we are today, and to use this information to think about implications for our field's future, particularly keeping in mind the interactions that we have with gender and sexual minorities. So I wanted to start our journey together by thinking about a case. This is a fictional case that I wanted to use just to walk us through how someone who was gay would be treated in medicine throughout various stages in history. So let's start with John. He is a 33-year-old cisgender man who describes having same-sex and same-gender attraction and has actually acted on these feelings with intimate partners in the past. He has emotional conflict about this part of himself, and he fears his community and family would condemn him. So I want to start with what would happen today. Well, today, John might walk into his UCLA primary care clinic and see his primary care doctor. His doctor at UCLA happens to be a UCLA LGBTQ plus champion, and given his distress, he's referred to the UCLA Empower Clinic for affirming care, and he starts therapy. With his therapist, he works to accept his identity and build a supportive environment for himself. This positive outcome, I think, is what we would hope for. And while there are varying experiences in the world, in the United States for LGBTQ plus folks, both good and bad, even today, I think this experience we can all agree is an outcome that we would hope in this modern age for John to get care. But it wasn't always like this. And I think I wanted to think about how we got to this point and where did we come from. And so going all the way back before the 19th century, John's experience, as you can imagine, would be vastly different. So what would his experience be like? Well, until the 19th century, John's behavior and feelings would predominantly be viewed as a moral, legal, and religious issue with not much interaction with the medical fields. There are many laws that were put into place, with the first secular law being made in 1533 by King Henry VIII in England that outlawed sodomy, buggery, and, quote, crimes against nature. In this era, if John was found to have homosexual activity, he would have been accused of breaking this law, tried, and if found to be guilty, he actually would have been hanged to death. In the 18th and 19th century, John's experience might be largely similar, but we also start to see some shifts and thoughts around same-sex relationships. During this era in the Enlightenment, for example, there was a lot of reform and interest paid particularly to figuring out what is the public sphere versus what is the right of the state to interfere with people's right to privacy. And you start to actually see some of these sodomy laws be abolished, particularly in places like France after the French Revolution. However, in many places, these sodomy laws continued. For example, in the American colonies, they definitely continued. One difference that John might experience during this time is that we actually start to see medicine become more involved and more interested in homosexuality. And this was mostly in the setting of medical legal cases. So thinking about John's case in 18th, 19th century, John might have been arrested for violating a sodomy law and having illegal sex. He, at this point, would be examined by a doctor to find evidence of his crime. The medical examiner would look for physical stigmata and examine psychological and behavioral traits, looking for femininity or cross-dressing as evidence. The examiner might have used a text by the physician that I showed here, Dr. Auguste Trudeau, who wrote a book, Medical Legal Study of Offenses Against Public Decency, and use it to help prove a crime was committed. So you start to see during this area that physicians like Trudeau actually start making arguments that same-sex behaviors are a form of insanity, and that helps to plant the seeds for medicine and psychiatry to be more involved in understanding these behaviors. And we actually start to see this greatly expanded in the 20th century, where homosexuality is medicalized more in works such as Sexual Inversion and Psychopathia Sexualis. Both of these books coined the term homosexuality. These works argue that homosexual behavior is congenital, a hereditary condition, and not a matter of immorality. It is a behavior to come under medical and psychiatric care and not one to be criminalized. And so during the 20th century, you start to see medicine and psychiatry taking on more of a role in trying to remove homosexuality out of the legal sphere and more into the medical and psychiatric fields. With this context, let's explore what would happen to John in this era. So it is, let's say, 1971. John's family is worried about his behavior and heard about homosexuality and a little bit of how doctors treat it. They're looking for a psychiatrist to help him. Depending on the psychiatrist that they go to, he might receive different types of help. Maybe his psychiatrist follows the father of our field, Freud, who believed that humans are constitutionally bisexual and that homosexuality could be the natural outcome of normal development. He might have read Freud's letter to an American mother, which said homosexuality is assuredly no advantage, but is nothing to be ashamed of, no vice, no degradation. It cannot be classified as an illness. We consider it to be a variation of sexual function produced by a certain arrest of sexual development. Many highly respectable individuals of ancient and modern times have been homosexuals, several of the greatest men among them, Plato, Michelangelo, Leonardo da Vinci. More likely though, John's psychiatrist probably would have cast aside Freud's writings because the field at the time started to take more of a pathologizing view that argued that John's homosexuality could be cured. These views would have been heavily influenced by Sandor Rado and after him Irving Bieber. They argued that homosexuality was development gone awry and described the pathological family type that led to homosexuality, a detached father and an overbearing mother. Homosexuality was something to be cured, and they claimed in one study that they did to have a cure rate of 27%. With that in mind, John's psychiatrist most likely would have used the DSM to diagnose a mental illness of homosexuality, which was added in the DSM initially in 1952 as sociopathic personality disturbance, and then finally in 1968 to the DSM-2 as homosexuality itself under personality disorders. So after John is diagnosed, the focus of his treatment would be on curing him. He would undergo intense analysis and perhaps aversion therapy or even ECT. This treatment would take years and fail. John would still have same-sex attraction and internalize that who he is wrong and not natural. But in just 2 years from 1971, John's experience would be vastly different, and our field would take an abrupt about-face. New research and work by Kinsey and UCLA's own Evelyn Hooker would start to challenge the status quo and challenge the idea that homosexuality is a pathology, to be cured. Civil rights activism, feminism, and LGBTQ+ activism of the 60s and 70s also inspired challenges to the medical field for pathologizing homosexuality, and they argue that our view of homosexuality at the time exacerbates social prejudices for gay men and women. This activism comes to a boiling point when Dr. John Fryer, dressed as Dr. Anonymous, addressed his colleagues at the APA in 1972 and argued for removing homosexuality from the DSM. He talked for 10 minutes and received a standing ovation by his colleagues. Finally, in 1973, homosexuality was removed from the DSM-2, though remnants still remained. Instead of having homosexuality itself, it was changed to distress from being gay and called it sexual orientation disturbance, and later ego dystonic homosexuality. In 1987, this was officially removed from the DSM, though distress from your sexual orientation would remain until the DSM-5 removed it completely in 2013. So that journey, I think, takes us back to John's experience now. From before the 19th century into the 18th century, where he would be considered a criminal, to now getting affirming care through his doctor and psychiatrists and therapists. John's experience is hugely different from even just 50 years ago. So where does this history leave us? I think some of the lessons that I took away from this is understanding the deep connection psychiatry has with society and its ability to play a role in either helping or exacerbating social prejudices. The questions that come up for me is, what is our role in understanding the impact our diagnoses have on society? And more contemporarily, are we repeating similar history with gender dysphoria? These are just a few questions to ponder and one I don't have answers to, but hope that we can think about together as a field. Thank you so much for your attention, and I hope that this journey was enlightening and helpful.
All right. Thank you so much, Dr. Flores. And wanted to say thank you to all three of you, Dr. Flores, Dr. Mendez, and Dr. Youssef, just for the bravery that it took to come and speak in front of a large audience like this, and just for all the time that you put into preparing these talks. So we have some time now for our questions and answers. So go ahead and put some questions in the chat, and we'll present them. And a reminder just to make clear who you're addressing the question to. All right, we do have a question that came in directed to Dr. Youssef, asking about any research that may have been done on MDs in terms of suicide rates or anxiety in terms of religious background, whether having strong religious or beliefs or cultural connections does help to attenuate that at all.
So I just did some research on this right now to answer this question, but there aren't any studies specifically about MD suicide rates being affected by religious background, but there are studies for the general population, and there's actually conflicting results. So there are some studies that show that having a religious background or a religious affiliation is protective against suicide attempts and suicidal ideation. And there are studies that show that it is not protective. And the meta-analyses that comment on these conflicting results say that suggest that we may need a more nuanced understanding, because just religious affiliation doesn't appropriately assess how strongly the religious beliefs are held, how strongly or closely they practice, all of which may affect how protective it is. For MDs, I did find one article that talked about how how suicidality may be affected by religion, but it was more postulating that religion may be protective, which I think which I think may be assumed based on how we perceive religion.
Mm.
And I see someone in the chat added that there's research on the maladaptive and adaptive religious practices that are linked to suicide risk, and I can imagine so. Thank you for adding that.
Thank you. And a question that I had actually for Dr. Mendez. I think I was very interested in kind of learning more about this particular type of therapy. If somebody has that interest, is this something that you feel like can be easily integrated into someone's practice? And if so, like how would you go about that? Are there particular trainings, books that you would recommend?
Yeah, so EFT was developed by Sue Johnson and Nestle Greenberg. There is a really good book by Sue Johnson called Hold Me Tight. That's how I was introduced to this line of therapy. I think it's a great book. It really explains sort of all the dynamics, the attachment. I do think that there is like a more systematic process to get certified as an EFT therapist. But I also think that, you know, naturally in psychotherapy, we're always going for the affect. And I also see this like as a continuation. And so I do think that, you know, by reading this book and getting more familiar with it, it is something that can be incorporated into therapy sessions. And there is also some ramifications of this line of therapy for individuals and for family. So, yeah.
And do you feel like it's something that's fairly compatible with like even a med management visit, or is it something that kind of needs its own carved out space for?
I could see how it would be very challenging to work that through med management, just because the process of slowing down and exploring deeper emotional experiences is difficult and it takes time. And I can see that it would be harder to try to incorporate that in med management, unless it's a combined therapy med management practice.
Yeah, that makes a lot of sense. Thank you. I think on a similar note for Dr. Flores, any steps that you might recommend for somebody who's wanting to, you know, be more of a LGBTQ plus champion in their everyday work, even if they don't have like that official title? What steps would you recommend somebody to take right now?
Yeah, I mean, I think for me, it's always about education. I think a lot of times I've heard, and even with myself, like people sometimes get uncomfortable if they don't know kind of how to use pronouns, they don't know, or kind of if they make a mistake, they get worried. And so I think for me, it's always about kind of educating yourself and kind of putting yourself out there and maybe stretching yourself a little bit to learn more. And obviously, like going through and learning the history isn't absolutely necessary, but I think learning kind of what that affirming care looks like, and learning kind of how to be a champion for these populations would be an important step to take.
Any resources that you found particularly helpful that you could point people to?
Yeah, I mean, I think UCLA itself has a lot of great resources. I think that there are education modules that they have online. I think through the LGBTQ plus champion website that you could take just to kind of start kind of your journey and learn a little bit more. I think that there's a LGBTQ plus initiative at UCLA Health that I think puts on education seminars, and usually will send out information. So definitely kind of keep an eye out for that if you want to kind of learn more and kind of give yourself more of that education.
Yeah, I agree. I've made use of some of UCLA Health's resources for myself or to refer other people to, and they're very, very high quality. So definitely a good place to start. So some good questions rolling in. Feel free to send more. For Dr. Youssef, first they said, thanks for an excellent presentation. And then asked, ironically, do you see traits of narcissism potentially as a protective factor to counter anxiety in physicians?
I think that's a great question. And what I think it's probably protective until it isn't. And the way that I think about narcissism is that there is a core of low self-esteem and this narcissistic defense that the person has put up or has been generated through their life experiences to protect themselves from accessing that core of low self-esteem. And when I've seen people with narcissism come to care is when they are, it's usually later in life when there is something in their life that is falling apart that causes them to feel unhappiness. So I think it's possibly protective in their earlier career from acknowledging or accepting responsibility for their mistakes. But I think there may be a point in their life where they realize that they are unhappy or they feel that unhappy and don't understand why, or they realize they've gotten to a place where they don't have the family and personal relationships that they want. And this brings out the point that I also wanted to make in the presentation, that what I commented on is just a few things that can contribute to anxiety in doctors and a few things that we can do about it. But yeah, so the personal relationships also affect people's like happiness and distress. So I think later on in life, when kind of they see their life not turning out the way they want it to, or their career not turning out the way they want it to, that distress can come up even higher than it would for someone without narcissism.
Yeah, I think that makes a lot of sense. And a follow-up question to the discussion of suicide, and I'm sure like the underlying depression, anxiety, and positions that tends to drive that. Do you think that there's any link to social media?
I think social media has, I don't know the literature myself, but I think social media, from what I recall hearing about, has increased the risk of suicide. There's so much comparison. Something I didn't talk about is comparison of self to others, which is something that I definitely do, and I've heard my peers do. So my friends in other specialties feel like they're comparing themselves to their colleagues that they're working with. And even right now, listening to the presentations that came after me, I was thinking, oh, those were really great. I should have done X and X better. And so I feel like social media just magnifies the ability, the opportunities for comparing self to others, both in like personal and professional ways. So I think probably it has, or at least contributes to suicidal ideation.
Yeah, thank you. For Dr. Mendez, I think what you presented was really looking at the emotional focused therapy in the context of like a romantic partner relationship. But you have a question coming in, focus more perhaps on like child psychiatry, asking what process has been used to help repair parent-child relationships, and does this vary at all with the child's age?
I don't think I don't know a big part of this answer, but I do know that attachment, again, it's from early in infancy, and it can be disrupted when there are cases of postpartum depression, when a mom may be internally preoccupied and not connecting with an infant or responding to the infant's attempts for connection. And I know in that scenario, mothers can get treatment, and they can get actually education about what is attachment, the different types of attachment, and they can get coaching in how to tune in into their infant's emotions, how to mirror the infant, mirror the infant's emotions. And so I know that this is done in our community. As that infant grows, I have to learn still how that changes through the years.
Well, thank you. And another follow-up question for you is, I guess going back to more the romantic life partner, how do you perceive when it appears that one of these partners is not really invested in or dedicated to the other partner or to the therapeutic process, if they're repeatedly dismissive or stonewall these attempts? Any guidance or recommendations from this form of therapy on how to approach that?
Yeah, so there are a couple scenarios here. So it may be that partner is, again, has a wall up, feels attacked. And so then it makes it very hard for this partner to become emotionally available for the partner who's seeking that connection. Mm-hmm. And so it would be very important to slow down and explore what is happening behind that dismissiveness. Is it feeling ignored too? Is it feeling attacked? Is it feeling like a failure, not knowing what to do and giving up? Is it that the person's sort of stuck in maybe like superficially like problem solving cognitive level? And so, you know, there may be so much underneath that dismissiveness. That's one possibility. The other possibility is that the person is not invested, or, you know, there are contraindications to emotionally focused therapy, and that is if one partner is not emotionally invested and it is making constant threats to leave that relationship. So it would be almost impossible to then make a secure attachment there. Or two, if there's physical violence, verbal violence, in those cases, this is contraindicated.
Yeah, that makes sense. All right. And a question for Dr. Flores. You talked a bit about how kind of broader societal forces and trends influence kind of the doctor-patient relationship at various places throughout history, and specifically on issues of LGBTQ plus related to this. Are there things that you feel like doctors or other healthcare professionals can do to kind of influence society as a whole? So kind of in the reverse.
Yeah, I mean, I think absolutely. I think both intentionally and unintentionally. And I think that one of the things that I found interesting about kind of learning about the history was that I think when psychiatrists and medical professionals like took on homosexuality as kind of got more involved, it was kind of out of they felt like they were doing the right thing. They felt like we're removing this from the legal sphere. They shouldn't be criminalized. We're kind of doing that, but it kind of had a negative consequence from that. And so I think that happens a lot. And I would even maybe put out there that maybe like with gender dysphoria, that it's something of a similar situation, where I think that we have a view of like, we're not saying that transgender people being transgender is a mental illness, but there's distress from not having having a misaligned gender, and so that's the mental illness. But I think when we do that, like you have politicians, like I put in my slide, like Marjorie Taylor Greene, or you have politicians who say, see, look, it's a mental illness, and use that to justify taking away rights, use that to justify criminalizing, or are making kind of the lives of transgender folks even worse. And so I think that it falls kind of on us as physicians and psychiatrists to be aware of like our diagnoses and how that impacts society. And I do think that there is a role for us in advocacy, in kind of explaining what this means, and kind of looking closely at is this diagnosis doing more harm than good?
Yeah, I think that's a very important, I would even say essential perspective for everyone in the healthcare field to have. And with that, I'll go ahead and bring the Q&A to a close and wrap up our grand rounds for this morning. But just wanted to say thank you one last time to Dr. Youssef, Dr. Mendez, and Dr. Flores. And thank you all for your attention, and enjoy the break from grand rounds, and we'll see you all in the new year.
Thank you, everyone.
Thank you.
Thanks.
Thank you.